This week's lecture will be looking into respiratory disorders. Firstly, just to have a look through the lecture contents. So we will be focusing on two main respiratory disorders this week. We'll be looking at the etiology, the incidence, describing some of the epidemiology behind both of these conditions, the pathophysiology, and as well as exercise prescription for both of these conditions. So firstly, what is a respiratory disorder? And as the name suggests, we're talking about a disorder at the lungs and the structures involved with the lungs, so your bronchi, bronchioles, and alveoli. There are two main classifications when it comes to respiratory disorders. So there's either obstructive respiratory disorders or restrictive respiratory disorders. In this week's lecture, we'll be focusing only on obstructive disorders, which are COPD and asthma. But the general definition behind an obstructive disorder is the inability to expel air from the lungs efficiently. So when you're looking at the pathophysiology behind each of these this week, you'll notice that there will be restrictions in these individuals as to how that they can effectively remove that air from the lungs. However, in a restrictive disorder, it's the opposite. So it's the inability to inspire air efficiently into the lungs. So it's the absolute reverse. So what will happen behind the pathology of these particular conditions is that when an individual tries to take in air, there's a resistance to this, which means that they can't fully. The first respiratory disorder we'll have a look at is chronic obstructive pulmonary disease, or COPD. Now, having a look at the incidence of COPD in Australia, so COPD was the fifth leading cause of death in the country in 2012. So more than 1 in 20 Australians aged equal to or greater than 55 have COPD, and it affects an estimated 9.2% of Indigenous Australians. So the prevalence of COPD is 2.5 times higher in Indigenous Australians. So it is particularly important if you are working with that demographic, just being aware that the incidence of COPD is definitely higher in these individuals. Having a look at the hospitalisation burden, so COPD had 9,700 hospitalisations from 2012 to 2013 amongst Australians aged equal to or greater than 55 years. And the economical burden is massive. So it's $929 million that was spent with admitted patients, out of hospital medical services, as well as prescription medications for these individuals. So just to give you the breakdown regarding the percentages for that pie chart there. So 57% was due to admitted patient costs, 23% was due to the prescription medications, and 19% was due to out-of-hospital medical services. Having a look at the statistics from the World Health Organization. So globally, COPD still has quite a large impact. So the first one says that 65 million people have moderate to severe chronic obstructive pulmonary disease. And more than 3 million people died as a result of COPD in 2005. So that's corresponding to 5% of all deaths globally, which is huge, again, as a number. And unfortunately, the trend for COPD is getting projected to be quite large numbers that will increase over the next decade or two. So total deaths for COPD are projected to increase by more than 30% in the next 10 years. And the prediction is that by 2030, that COPD will become the third leading cause of death worldwide. Now let's have a look at a breakdown of COPD. It is described as a disease state characterized by a progressive limitation of airflow in the lungs, which is not fully reversible by prescribed medication. Unlike asthma, when we do have a look at that, when we do give them particular medications, we can actually alleviate the symptoms and actually reverse that through providing them the correct medication. So COPD actually encompasses, or is like an umbrella term for a bunch of chronic pulmonary disorders. But the two main ones that are involved with COPD are chronic bronchitis, which is airways inflammation, involved with also mucus gland hypertrophy, and also emphysema, so damage to the anatomical structure of the lungs, but particularly the alveoli. And also in COPD, a large problem with it is the fact that it actually involves the constriction of smaller airways. Now that there has been a bit of an established understanding of what COPD does entail, we'll start off with explaining bronchitis. So as mentioned previously, bronchitis is an inflammation of the bronchi, so the bronchi tubes which bring in air into the lungs. So hopefully you remember from your anatomy, those two main tubes that do provide air to both the right and left lung. So this inflammation occurs in response to chronic exposure to noxious particles or gases. So in both bronchitis as well as emphysema, smoking is the number one cause for this damage to these particular anatomical structures. However, when it comes to bronchitis, viruses can also cause damage and cause the inflammation, as well as viruses, bacteria, and any inhalation of certain kinds of irritating chemicals. So this actually goes in line with types of occupational hazards. And unfortunately in Australia, there is a very high rate of occupational based or occupational related COPD cases. So essentially what happens when there is this inflammation, when there is this chronic exposure to either particles or gases, is that the cells lining the bronchi then become irritated. And the tiny hair cells that are lining the bronchi, called cilia, usually trap and try to take away any foreign objects that are trying to get in through the airways. However, because of that inflammation, they actually stop working and don't do their job correctly. So then in response, what happens is that these irritants then build up and then become a trigger, which then is associated with irritating the bronchi even further, then causing more inflammation, which then causes the passages to become blocked, therefore evoking any of the symptoms that are involved with COPD. So particularly shortness of breath, your wheezing, and the actual sensation for them to feel like it's difficult to breathe. Now having a look at emphysema. So as mentioned previously, it is particularly looking at the alveoli, and what happens is that the structural damage to this site loses the flexibility and then results in tear in the alveoli walls. So it's a good idea to sort of think about it like an old rubber band when you start stretching it, and then it obviously hits its yield point or point of failure, and then eventually starts to have tears and breaks. So very much the same with what's happening with the alveoli walls. And this in turn actually reduces any kind of elastic recoil that the alveoli walls did have in order to help the actual force to take air out from the lungs. And unfortunately, as a result of this, there is a reduction in something called radial traction. Now, radial traction is the force that keeps the actual airways open when we are trying to expel air from our lungs. And unfortunately, without this alveolar support, this means that due to the fact that there's a reduction in radial traction, the smaller airways can now actually collapse during expiration, which is a bad thing. So the combined effect of airway obstruction and reduced expiratory driving forces then increase the time needed to actually fully remove air from the lungs. Having a look at the risk factors for COPD, and I will let you read the list in your own time, but ones to just sort of point out definitely is smoking, and as mentioned previously, it is the number one cause for COPD, so as it says there, accounts for 85% of cases. But interestingly, passive smoking is also a high contributor, a large risk factor when it comes to COPD. And approximately 20% of cases that are COPD patients actually have never smoked before. So you can see just from that statistic alone how potent smoking is as a risk factor to developing these types of pulmonary disorders. Another big one is exposure to occupational dusts and chemicals. And as I'd said previously, Australia has one of the highest rates of occupational-based COPD cases. The common signs and symptoms of COPD. So while these look pretty stock standard when you are reading them, it actually is quite a bit of a reality hit when you do meet someone with severe or moderate COPD and how severe each one of these symptoms are, particularly the wheezing. So initially how this is diagnosed is that an individual will usually have a regular cough, and that cough will usually be for about 4 to 6 times within the day. There is some form of mucus or sputum production, and they have wheezing attacks. Breathlessness or dyspnea, any sort of chest tightness that is associated with that, and also a loss of appetite. Before I explain the actual diagnosis of how through spirometry they do diagnose COPD, what I'd like you to do is actually read through the terms for each one of these measurements that are involved with spirometry, so then you understand what I'm talking about when we move on to those slides. Yes, and also don't forget to read these ones as well. Okay, so let's put these definitions into practical terms. So having a look at some spirometry data. So on the left, we have the normative-based data, which is to do with normal lung function. And we have 3 different types of pitches that we have underneath abnormal ventilatory function. So we're just going to focus on obstruction because we're looking at obstructive-based disorders. And I'll just pop these up first. So we're looking at the forced expiratory volume in 1 second, forced vital capacity, and also the peak expiratory flow. Remembering that an obstructive pulmonary disorder or respiratory disorder is involved with the inability or the lack of ability to actually expel air from the lungs fully or efficiently. So it should make a lot of sense when we are looking at the data. So I'll just remove one for a sec. If we're looking at forced expiratory volume over 1 second, that we're clearly not going to be able, or in these individuals who have obstructive disorders, we are not going to be able to forcefully expel as much air as those who do have normal lung function. And as mentioned in the pathology, that these individuals do require a longer amount of time to actually expel all the air or the majority of the air from their lungs back out. So you can see that there with the forced vital capacity taking a much longer time compared to the normal lung function with the graph above. However, in the graph below, so again, very much having a good sort of explanation tying in with your forced expiratory volume of 1 second and forced vital capacity with the picture above, your peak expiratory flow you would expect would most definitely be substantially less compared to that of someone with a normal lung function, which is clearly highlighted in the picture below. So just so you understand with the axes here, so the x-axis obviously is talking about the volume of air. However, below the x-axis there on the y-axis is inspiration, and then clearly above that is expiration. Looking at the spirometry grading criteria for COPD severity, now I will let you look at, say, the grading system in your own time. However, it is important to note that at each one of these stages, what potential differences, what impact the severity of COPD will have on firstly their symptoms, but also their quality of life. So having a look at the column on the far right, you should notice that there are particular descriptions that will facilitate in the diagnosis, the spirometry diagnosis, and what severity of COPD the individual will have. So for 1, so mild COPD, this person might not actually know or be aware that they might have some kind of compromised lung function, because in their daily life, they're not really having symptoms that do interfere with how they function. But then you can see progressively through the grading system that there are increases in severity with the symptoms. And then there are different points of exertion where the individual will feel particularly short of breath. Let's have a look at more of the practical side with dealing with these patients. So in COPD, you should hopefully straight away be thinking about monitoring their shortness of breath or dyspnea, as well as their oxygen saturation. So we did have a quick look at this in week 1 when it came to measuring out something with a pulse oximeter. And I'll have a bit more of a detailed explanation as to why it is really important to be monitoring oxygen saturation. However, to start off with, the dyspnea scale, which is straight out of your ACSM guidelines, is graded from 1 to 4. And hopefully looking at the descriptions of the symptoms, you should notice how uncomfortable, particularly the exacerbated shortness of breath, gets for these individuals. So for those who have mild COPD, they can usually exercise quite comfortably if you give them a sort of lower submax based exercise. And it's only sort of at the more extreme higher intensities where the shortness of breath will become quite problematic. But when you are dealing with those who do have some kind of moderate to severe based COPD, even at rest, they're looking at grades of around 2 to 3, which makes it very difficult for you, especially if you're inexperienced with giving exercise prescription to these individuals, with how you can tailor your exercise around that. And hopefully from this lecture, you'll get a bit more of an idea on how you can do that, and a lot more effectively without making it too uncomfortable for these individuals. An alternative to the ACSM guidelines 1 to 4 dyspnea scale is the modified Borg dyspnea scale. So for each number there, so from 0 to 10, besides a couple there is a description alongside each number that will describe how difficult it is for the individual to breathe during that time. So just make sure that when you are collecting dyspnea on a scale, that it is consistent throughout the time that you are monitoring that individual, because if you're moving in between scales, that's where your data becomes invalid. And it is very important to have consistency when you are looking at some form of variable. To have an understanding of oxygen saturation, it's easier if we just look back at the oxyhemoglobin dissociation curve. So firstly, just remembering that red blood cells have hemoglobin, and hemoglobin binds to oxygen, which is why red blood cells carry oxygen around the blood. And when we breathe air in, we have a particular, partial pressure that is involved with oxygen as well as CO2 or carbon dioxide that is then passed into our lungs. And if we have effective gas exchange, which we would have in normal lung function because there isn't particular structural damage to the alveoli or the bronchi or any other structures involved with the pulmonary system, we then would expect to see that the percentage of saturated hemoglobin, so saturated means how oxygen bound to hemoglobin, at rest in normal lung function would be between 95 to 100%. And that's good news. So if you have a look at the curve here, so the curve is shaped like a sigmoid or S-shaped curve. And from pretty much 90 to 100% of O2 saturation, we can see that there is a bit of a plateau effect. So a bit of a safety sort of net for any sort of partial pressure differences that occurs between about 75 to about 100 to 110 mils of mercury in terms of partial pressure of oxygen. However, in pulmonary disorders, so looking at COPD, we know that there is alveolar damage, particularly looking at the emphysema side of COPD. And unfortunately, this damage in the alveoli then basically changes or makes the gas exchange within the lungs less efficient. Therefore, when the gas exchange is then going into the arterial blood, we actually have a reduced partial pressure of oxygen because of the structural damage that has occurred at the lungs. So in the emphysemic-based pathology, there is also an increase of dead airspace. So due to the tear in the alveoli walls, we now have spaces within the lungs that do not effectively have gas exchange. So that's sort of the definition behind dead airspace. So as we can see, if now for an individual who did have a emphysema and they did say hypothetically have a partial pressure of oxygen that is now leaving into the arterial blood at about 60 mils of mercury, we can see that on the graph here, we're starting to hit that slope or going into that exponential drop in oxygen saturation to hemoglobin. So what that means in terms of the action of oxygen in this case is that once we get past the safety net or past that plateau and into that drop, it means that oxygen wants to just offload off red blood cells and go to tissues that need the oxygen. So this partial pressure system works quite effectively when we do go from arterial blood into working tissue, namely the muscle, which is what we would have seen in the ex-phys course. But really not great when you're trying to get from the lungs into arterial blood in the first place. So remember, we need a high pressure gradient, so going from high to low, to make this gas exchange between tissues even effective in itself. So this is why for these individuals who do have destruction at the lungs, they then have all these particular symptoms of shortness of breath, the wheezing, the difficulty of performing activities, of living with an increased sort of difficulty because they aren't getting oxygen effectively through gas exchange. So while they're still breathing in the air, the fact that they're not having that gas exchange to actually make sure that the partial pressure of oxygen is maximized, then in turn makes it very difficult for them to have effective gas exchange at other tissues. So the fancy piece of equipment that we use to monitor oxygen saturation is the pulse oximeter. It's a fantastic piece of equipment because we can use it during exercise because it's so portable. So it's just the small device that's pictured there on the fingertip. So blood oxygen levels for a healthy individual or those without any damage to the pulmonary system is around 95% of saturation or above while at rest. Just so you are aware, the minimum safe level of oxygen saturation while exercising is 90%. And in COPD patients, and you will come across this if you end up doing placement with cardiopulmonary individuals, is that you'll actually notice that there are quite a few individuals who do have severe COPD who will arrive with an O2 sat of less than 90%. So what are you going to do if this is the case for this individual, if they turn up to the hospital or if they turn up to your clinic? What are you then going to do? So there is a way around that. We can then make sure that the individual is then evaluated to see if they actually require supplemental oxygen when exercising. And usually for an individual who does present at rest with less than 90% O2 sats, and there is a bit more of an extensive criteria behind what the requirements are for supplemental oxygen. But if they are having particular difficulty with their daily activities, due to their breathing, then usually they are given some kind of supplemental oxygen. So the reason that it is important that they are evaluated is that because they're not getting sufficient oxygen while they are exerting themselves, this then leads to poor muscle function, which then makes it harder for any sort of training adaptations. So super important for you, if you're giving an exercise program for these individuals, is to double check if this person does need supplemental oxygen, because it can interfere with the progress of your exercise program. So a good portable device is the pulse dose oxygen dispensing unit. So it's great because obviously they just breathe in the oxygen and it fits like a backpack, and really easy for your exercise session because it gives about approximately 2 hours worth of supplemental oxygen. So clearly enough usually for these individuals, but for their own daily sort of needs, they probably have another unit that they have at home, or they've worked out a system with the hospital or their specialist. Moving on to exercise testing and prescription. Before we even go into exercise prescription, we first need to do some form of exercise testing. And in COPD individuals, it is extremely important to look at their cardiopulmonary function during exertion. So preferably, and this is also if you have access to these facilities, with a graded exercise test on either a treadmill or a cycloergometer, and looking at more towards your gold standard protocols, if you can incorporate gas analysis into your exercise testing, this actually provides you with great insight for these individuals and definitely giving you an edge in tailoring their program very individually to meet sort of the onset of their symptoms. So when it comes to gas analysis, the variables there should be familiar. So we have volume of expiration, respiratory rate, volume of oxygen, volume of CO2, heart rate, and O2 sats. And with gas analysis, the best thing that comes as a result of that is that we can actually look at a point called the ventilatory threshold. And the ventilatory threshold is something you should have learned about in exercise physiology. However, just to recap. So when we are monitoring an individual with gas analysis, we can actually see the trend in which a person actually consumes oxygen as well as breathes out CO2. And for every individual, there is a point at which that firstly they meet their lactate threshold, and there's also a point at which, due to the metabolic rate, and that's usually due to an increase in lactate levels, a person will reach their ventilatory threshold. Now, their ventilatory threshold is the point at which their breathing rate or the respiratory rate exponentially increases with increasing workload. So you could imagine that an individual with COPD who already is experiencing difficulty in breathing and not being aware of what workload might start to evoke that, it is great that if you can do this with an exercise test and find the exact point at which this occurs, you can make the initial experience to exercise a lot more comfortable for them. However, going back to the exercise physiology behind the ventilatory threshold and also lactate thresholds. So because these two thresholds correlate quite well, hopefully you remember that the lactate threshold is the point at which we actually have the most significant physiological adaptation. So from that point onwards. And ideally, what we would like to do with these individuals, just because they are so deconditioned generally, is to get them to a point at which that they are either exercising at their lactate or ventilatory threshold or just above that. So if you find out that point, the best bit is that you can then initially prescribe about 10% beneath the ventilatory threshold, and then progressively increase your exercise prescription to eventually either be at the ventilatory threshold or beyond the ventilatory threshold for initially about 10%. However, in reality, we might not have access to this equipment all the time because it is quite expensive. So generally there are field tests that we go with, and the timed walk test, so your 6-minute walk test, is a very, very common one that is used in COPD populations. So 30-meter track, or you can modify even that distance depending on what area you're working in. Okay, have a chair available for these individuals. Because they are deconditioned, they might want to take a break, okay, but encourage them to keep going on with the 6-minute walk test. And also stair climbing. So for these individuals, a big thing that you will notice, and the literature also supports this as well, is that leg fatigue is very significant in these individuals. And that's just because the quadricep muscles over time, just again because of this fear avoidance behavior of exertion bringing on or exacerbating their shortness of breath. So over time, the quadricep muscles atrophy. And this is why, say, in a cycloergometer test, stair climbing in particular will then possibly lead the individual to terminating the test based on leg fatigue. So in these particular protocols, you may not, or you might be limited to actually getting their true maximal capacity if that is the aim of your exercise test. You can see there with the R value, so the correlation, for those who don't remember what the R value is, comparatively to a VO2 max test on a bike, there is greater than 0.5, so we do have a bit of a stronger trend to how it correlates with the VO2 max on a bike, which is good. As I had mentioned, lower extremity strength is quite poor in these individuals. And so it should be first thing on your list when we're looking at muscular strength and endurance that a sit to stand test should be performed with these individuals. So your other usual functional based tests, so your wall push-ups, arm curl test, and if you are using a gym-based program, because these guys particularly need strength work, please go for RM testing. RM testing has been proven to be very safe in all types of individuals, even in chronic conditions. So if you are doing a 3RM, 5RM testing, definitely is safe. Obviously, go with the level of what experience that individual has. So usually you'd be starting off on machine weights. So your chest press 3RM, seated row 3RM, leg press 3RM. So at least you're getting the major muscle groups with that. So other additional tests to consider: timed up and go test, back scratch test, particularly if it is an elderly individual. And when we're talking about COPD, we're usually talking about elderly individuals. Any other range of motion testing, so through the use of a goniometer, and if they present with any sort of musculoskeletal problems. The Berg balance test, and you can conduct a St. George Respiratory questionnaire, which looks at their symptoms and how their COPD does affect their quality of life. In terms of exercise prescription for COPD, when it comes to aerobic exercise, you most definitely want to incorporate large muscle groups, as per any other condition. So walking and stationary cycling is usually the way to go. And as a note, it says any mode as long as it does not promote excessive shortness of breath. Now, there is a way that we can manipulate aerobic exercise to try and reduce this amount of excessive shortness of breath. And an easy way to do that is through interval training. Now, naturally, I'm not talking about going to extremes of intensity with this, but picking a specific intensity. So here we have a suggested intensity with the guidelines of greater than 50% of peak VO2. But let's say hypothetically with the individual, you had conducted a gas analysis graded test and you figured out where their ventilatory threshold was. You could actually start your interval training, say at 2 or 1 minute of a work rate at that 10% below the ventilatory threshold, and then manipulate your rest ratio. So let's say 1 minute on, 2 minutes off at a lower intensity of that, and then start working that into your aerobic session. And then progressively getting to the ventilatory threshold and then above the ventilatory threshold. Just to sort of reinforce the physiology behind the ventilatory threshold. So remember, your ventilatory threshold is highly correlated to your lactate threshold. And again, from your exercise physiology, your lactate threshold is the point at which we actually start to see significant increases in physiological adaptations to aerobic changes. So your mitochondria, capillary density, changes like that. So the frequency that we should be aiming for aerobic exercise is 3 to 5 days of the week. The note here says that upper body aerobic exercise may result in greater dyspnea. And the reason for that is just purely because we have smaller muscle groups, therefore increasing the lactate level quite significantly in a shorter amount of time. Lactate increases ventilation rate. Lactate threshold usually meets around roughly the ventilatory threshold. Therefore, this individual is going to feel like they're working quite hard in a shorter amount of time. However, just in experience, I've noticed that with some individuals, they actually tolerate arm cranking a lot better than, say, using a cycle ergometer, and that's just purely because they're using less muscle groups. So again, have a variety, but tailor the program around that you know that you are not promoting this excessive shortness of breath. So the minimum duration you want to sort of hit is 20 to 30 minutes, but remember, again, you can sort of build up to this, particularly if they are severely deconditioned, and eventually you want to reach around the 30 to 40 minute mark. It says here that 50% peak of VO2 for intensity. However, it is much easier to actually prescribe intensity for COPD patients, and it's actually a lot better through the RPE scale, as well as looking at how their dyspnea actually correlates to their RPE. So it says here also a consideration is that all COPD patients should be closely monitored, especially at near max intensities. And that's particularly because of that oxygen saturation and that desaturation at those points. So for resistance training with COPD, so you want to start off the individuals if they have minimal experience with machine-based weights or really easy free weight based exercises. Something to consider when you are taking a COPD patient as well is that there is something called the vicious cycle of sedentary behavior with COPD. So when an individual first notices the symptoms that they do have, and the fact that when they do push themselves, they do get short of breath and they get wheezy, and they find it really hard to do things just because of the difficulty of breathing, they then start to become less active as a result of the symptoms that they present with. Then what happens, unfortunately, with COPD is it progressively gets worse. Therefore, it increases their fear avoidance behavior to do anything at exertion. Therefore, then increases the inactivity that they do experience in their daily life, and then continually making their physical health worse. So this is why progressive resistance training is quite important, because these patients generally present with a lot of atrophy. And it is important that we start trying to get these individuals, particularly with their age group, some hypertrophy in their type 2 muscle fibers, but also so they can complete daily activities of living with as much independence as possible. So you've got some special considerations there. I will have a talk about inspiratory muscle training in a second. However, you want to try and get them in with some resistance training around 2 to 3 days per week. And again, as a consideration, particularly lower limb strength because it's particularly wasted away, particularly in the quadriceps. And it says here, 1 set of 8 to 15 repetitions to fatigue. So we're talking about a close to failure-based protocol. And eventually you want to try and obviously build up the sets that these individuals do. So the best bit about progressive resistance training is that you do actually have these breaks between sets, which allows them to have the chance to catch their breath and then continue on with the exercise. Okay, so inspiratory muscle training. This fancy blue device here is something that COPD patients can have access to. And essentially what it does is it applies a resistance against a person trying to breathe in, which is great because it's then trying to essentially create a resistance-based training for the inspiratory muscles around the rib cage. So this is to help facilitate the gas exchange process. But it is important to consider, so the reason that we do have this type of training is that quite a few COPD patients do have weak inspiratory muscles. And that's just because of the nature of the condition that they do have and the fact that they're quite sedentary as well. But the big question is, does it work? And when you look at the research, well, sort of beforehand, it was a bit up in the air about whether or not inspiratory muscle training really does work. And we'll have a little bit of a talk about whether IMT does work by itself and IMT in conjunction with exercise. So just to have a look at IMT from a research perspective, because it is a little bit up in the air about how effective it can be. This systematic review and meta-analyses had a look at studies and collectively looked at IMT versus a sham IMT protocol. So with their control groups, they were just giving them IMT programs that were substantially sort of less in intensity to evoke any sort of adaptations. We're going to first have a look at sort of direct inspiratory based measurements, and then we'll have a look at some more sort of functional based and symptom based measurements. For both peak inspiratory flow rates as well as the respiratory muscle endurance time, we can notice that the majority of studies on the forest plots are in favour of IMT, and in both of these actual outcome measures, there was actually a significant effect, and that's a very, very good thing. It just at the moment is telling us more about sort of they've got an increased ability to now effectively take in air because they've now hopefully increased that strength and endurance within the musculature around the rib cage. Then if we move on to looking at measurements that are a bit more, say, applicable for us, having a look at the BOW score for their respiratory effort, and this is a great one because it then gives them, and they will feel hopefully the feedback and the reap of their reward for going through the protocol, is that IMT training definitely has a significant effect at the effort that it takes for them to sort of just breathe. And for those individuals, this will have a huge psychological impact as well. But at a physical measure, so looking at the 6-minute walk test, again, the IMT-based intervention definitely had a good effect and a significant effect with improving the 6-minute walk test, just purely by strengthening up the inspiratory muscles. But then the question remains, does IMT training actually work as an additive effect in conjunction with exercise training? And unfortunately, pretty much with what the studies say is that it's still unknown. There really hasn't been a meta-analysis conducted to say that yes, it does, or no, it doesn't. But for now, pretty much the sort of conclusion is that we don't really know. But based on these results in IMT, we can say that there is definitely a positive benefit for an individual to perform IMT, particularly if they're too severely deconditioned that thinking about exercise for them is a bit intimidating. At least they can get benefits from this and then work towards a more physically active based lifestyle. If you have any questions, please send me an email. But that's the end for the first part of the lecture. Have a bit of a brain break and then go through asthma.